in Selbridge. And I suppose I just want to say that, I'm here with today with a lot of gratitude for the duty of care that I've received, and that thankfully, due to the therapy and the key workers and whatever, on most days I can live quite a good life, and I can get on and I can function quite well. And I suppose I just feel a great sense of gratitude that I live where I live, just looking at the statistics, and I just I would have had an experience in A&E that wasn't positive, so I can empathise with people here, and it was just good to hear the panel. Yeah. Thank you.
Okay, thank you very much. Now there was someone down, I think, in the back row. Yes, I've been, and then this gentleman, and then this lady. Yeah.
Hi, I just wanted to make a few personal points as a service user and a professional in not in mental health, but in primary care. I've been on both sides of the fence, so it's been interesting to see both sides. But just a few points. I feel that although the community model is the one we're striving for, home isn't always the best place to be, especially if you can't be alone, or if you need a supportive environment. And I sometimes feel we need somewhere in between hospital and home. So a sort of homely caring environment that's not institutionalized, but that is somewhere sheltered and protected. Another point that I've had also personal experience with is postnatal depression, which hasn't been discussed, and I really don't feel there's enough services in that area to accommodate the mother and child when the mother is in need, somewhere somehow that they could be supported together. And just the whole two-tier health system is one that really gets to me. If you don't have enough money to have private health insurance, you aren't entitled to the same services that those with private health insurance have. I've also experienced the gap for the adults that was mentioned. There's a lot for young people, but not as much for perhaps people over 25 in terms of support and support groups. And also I've experienced, I'm a young professional woman, but that doesn't mean I don't have mental health problems. I need support, but a lot of the support groups out there are for lower functioning individuals, and there's very few that accommodate high functioning professional people that also need support. Often you don't get the support, or you don't get a key worker, or you don't get home care because you're high functioning and you're almost too capable, as you said. So there's a bit of a gap there as well. And just the point about the GP being the first point of contact, that's €60 that has to be spent. Is there no other way, without having to spend money? If you really don't have it, you might not go.
Was the gentleman here? Was it? Yes, this gentleman here, and then lady here.
It was, sorry, I just want to respond in relation to...
If you could bring up,
in relation to Garda treatment or involvement. I'm a little bit reluctant to talk too much because it's in relation to somebody else, and I don't particularly want to identify them. But they had experience in relation to the guards where they were obviously behaving a little bit, let's say, what would be considered unsocial behaviour, but not in danger to other people. And twice they were charged. In the latter case, I was at the court, and the solicitor made a good case, I thought, on behalf of the person, in the sense of their previous life, and then some mental health, psychiatric experience or difficulty. The judge never looked at the person, and just took it up that you can't behave, you can't relate to the guards in this way, and found the person guilty, which I thought, in the circumstances, really both the guards and the judge, if they had training, and they should have training, they should see that this person has a difficulty, a problem, and instead of penalising them and making their situation much worse. Also, in relation to the same person, they were at a certain stage involuntarily admitted to hospital. After a time in the hospital, after a relatively short time, like they were put immediately on medication, after a relatively short time, myself being there as an advocate, as it were, not officially, just an informal basis, the person was taken off medication. That wouldn't have happened if I wasn't there. It just wouldn't have happened. So in often cases, my own sense of it is that there's, in most of the treatments, there's a bias in favor of medication, and that it's quite difficult for the person themselves to make the case in a very traumatic situation. Now, just briefly to say is that they continued to stay within that health unit, as it were, and on a voluntary basis. And they were able to interact, and they were able to go out of that unit daily, but go back there at night time. But after a couple of weeks, they were there was a lot of pressure put on for them to move on, because they were taking up a bed. And then very abruptly they were discharged without any contact with anybody else. So it seemed that the institution in that particular case, that body, was looking after its own needs rather than the needs of the particular person, because they weren't able to give the treatment that they wanted to give. It was felt then, just because the person, and it was obvious and it was acknowledged that the person was benefiting, but it doesn't seem in that situation, it didn't seem to subscribe to whatever criterion that institution needs. Right. There's also ongoing issues, but I don't want to take up more time in relation to accommodation and sheltered accommodation, because in that case also, after being involuntarily admitted, the agency in the sheltered accommodation made it a condition that they would be on medication to get back into the accommodation, which I felt is not their prerogative in the first place. But maybe I'll leave it at that.
Okay.
Thank you.
Okay, that sounds like another horror story, it has to be said. There was somebody here, this lady here, yeah, and then there was somebody down the middle. Oh.
My name is Susan Sargent, and we actually are from Dublin 12 Community Action on Suicide, and you were talking about assist training, Marie, I think, and the fact that everyone should have it, or certainly clubs, and we kind of identified that in the Dublin 12 area, which has a population of roughly around 20,000, to find that we've come up against blocks from the HSE about getting training in our area. We actually got Safe Talk training workshops this year for approximately 45 people, but we had to get it from a group that is run down in Cove that we got in touch with to come up and provide that training for the day. Now that's only a 4-hour workshop. The assist training is 2 days, and it's done specifically that way for the nature, because I've done it myself. To get the assist training through the HSE is near enough impossible, and I would ask the panel or anyone in the room who can answer to me why it is that training, which is provided free by the HSE, is so inaccessible. They will provide it Monday to Friday 9 to 5, but if you want to do it for clubs or volunteer groups or communities in any part of in Dublin or anywhere else, I assume, you cannot get that training. And I think, like first aid, it's the first port of call, it's the first person you meet when you're in crisis medically. When you're mentally in crisis, if you can talk to somebody who's assist trained, or preferably storm trained, which is the next step up from the assist, it would probably be that first link, that first contact, to get them to the medical professional, to get them to whoever after that. But I think, it's certainly one of the health and safety things for a work to have an occupational first aid trained person. So many people you work there. Certainly you should have somebody who's trained in mental health, and I think it's a disgrace that the HSE are blocking people from getting that training outside of office hours.
Right. Okay, point taken. I promised somebody else. Oh yes, this lady down here, then I'll come over to you.
Hi, my name is Geraldine, and I just have a question around...
Could you move the microphone a little closer?
Yeah, okay. Just around what I suppose I believe to be necessary, and I'm taken with Maria's story and your journey through the various systems, and what's coming through is what we all really need in the end of the day is to be able to talk and to have our stories heard. So and that takes time, and time, in professional life, in psychiatry, time is very much money. So the necessity for that long-term, ongoing relationship with somebody to talk with, who's trained and who you can develop a relationship with. That's long term. It's weekly. It's now. So what I'm hearing is that very necessary crisis assistance. In Dr. Gibbons' what you're providing. The crisis and then, but it's the long term talking and. Just in your opinion, Dr. Gibbons, what role have counsellors and psychotherapists have? How people can access that? How the HSE can assist people to be able to afford that? Because it is that's the reality of the work. So how and where is that? Where is the HSE on that? I know that there is an initiative where if you have a medical card now, and it's great that the doctor can refer you for counselling for 6 to 8 weeks, but it's short term. It's a bit like CBT, and it works to an extent, but it's the long term stuff, and I'm just wondering about that. Where is all this in that?
Any ideas on that?
Just a couple of words on it, really. I suppose, look, yes, what people will need at different times will actually vary. So some people will need a short-term intervention, and that may be what they are looking for and will meet their needs at that point in time. Other people, you're quite correct, of course, do have different needs that may need a different sort of intervention that might need to be planned on a longer-term basis. And often that is, it can come in different shapes. For some people, again, an experienced community nurse working according to an identified care plan can provide that structured long-term relationship, where a person just needs to have that long-term contact with somebody who understands them, knows them, and is familiar with their context, their social context, and so forth. For more formal psychotherapy, that's a long-term problem in terms of trying to make that available. It's a very clear need for a very long time, and I think in fairness to the HSE, there are some steps, and you've mentioned the program that's called CIPC, which is Counselling in Primary Care, which is being rolled out. It is for medical card patients. I suppose, according to Minister Riley, we'll all have medical cards one day, so maybe there's a
hold your breath.
A greater plan in the background there. But that's at least a recognition of the need, and it's a start to trying to put the resources in place. Beyond that, and for patients, for example, who don't have a medical, or service users who don't have a medical card but may not be flush with cash, especially in our current crisis, I suppose it's a matter of scrambling around, to be honest. There are actually quite a lot of services which are not generic, but may meet the needs of specific groups, such as the National Counselling Service, which provides counselling for people who've experienced trauma in childhood. There's a nationwide addiction services for people with addiction issues. So there are, different ways of accessing particular needs. I suppose there are still, we do need a much broader network of care, and I think that's a very fair point. I think it's a matter of continuing to lobby the HSE. I think it is a matter of pushing an opening door in terms of that the need is recognised, but then it's really just a matter of marshalling the resources. And this comes back to the earlier point everybody's making about talking to your councillors running up to the election, to your TDs, and continuing just to push as hard as possible to get the resource.
Okay, gentleman here, and then the lady beside him.
Hi, I come from the software sector, and I've just recently started looking at this area. And I guess, I said, first of all, I think it's very distressing to hear the stories of people's experience. I think from a positive point of view, I think it's very good to see some innovation going on in terms of what Gibbons is doing. And it's also very good to see that the benefits of that are being measured. I think one thing in terms of reform I think that's missing is the fact that was an ad hoc thing that you initiated yourself. And I think what is needed is that there's actually a formal innovation program. You can't have change unless you have innovation. So there should be a number of initiatives being kicked off and measured at the same time. I mean, just from spending a few days at Twitter, you can see various innovations happening around the world, that could easily be put in place quickly. Thanks.
Okay, thank you. Lady over there with the spectacles.
Oh yeah, sorry, I get very nervous when I'm speaking in front of people, but first of all, I'd just like to commend people who are sharing their own personal stories, especially the chap who was saying he's in crisis. You're very brave, I have to say. But one thing is, obviously it's clear there's problems with the systems and everything, but people forget that it's all to do with people's attitudes and individual services attitudes towards the people they treat. Like, I've had psychiatrists just abandon me, didn't give a crap basically. I was presenting in total crisis. They told me I wasn't depressed and I wasn't admitted to the service. That happened multiple times, not just once. And I'm not a unique case. I can imagine that's happened plenty of people, and a lot of those are not alive today because of that. Sorry, my mind goes blank when I'm talking. I get excuses. People would say, oh, you don't qualify as having this or this mental health condition, therefore you do not qualify as needing a mental health service. And if you say, well, I have this crisis, I have that, they just go, oh, that's the normal ups and downs of everyday life. Everyone has that. God. Another point I might like to make, one of the ladies was bringing up about a deaf person she knew. That's another issue to people with other disabilities trying to access mental health services. It's virtually impossible. Because, one of the excuses I was given at the start was they told me I had a learning disability I did not have, and that was their excuse for not allowing me to use the service when in suicidal crisis. Also, now, as you can see, I have quite a physical disability, and I cannot physically access my mental health service at all, so where am I supposed to go? And I'm sure that happens in most mental health services, that there are people that cannot access, whether intellectual, physical, or sensory disability, they cannot access their service.
Okay, thank you for that. Woman here in the front, and then I'll go down the back, yeah.
Hi, my name is Sarah. I'm a social worker on a family support team in Exchange House. We're the National Traveller Service. And I just wanted to say, I work with a family at the moment whose 16-year-old son was experiencing mental illness, and we don't actually have the facilities in Ireland to treat him, so he's actually in a unit in England. But it just doesn't sit right with me that any child should have to leave not only their home and their family, but the country to receive treatment. So I just wanted to...
Okay, thank you indeed. Woman down at the far back at the corner of the pillar.
Sorry, I know it's been mentioned before. I just want to remind people that the Samaritans are here. We're there 24/7 for those out of hours when you can't get anybody. We're there on the phone for 24/7. We also have people can call to us in Marlborough Street. In the Dublin branch, from 10 in the morning till 10 at night. We have you can contact us by email or by text. So just to say that. So for those times when people need it outside of office hours. Okay.
Okay.
Thanks.
Okay. Thank you. This woman here, yes.
Hi, my name is Mary. I'm actually a trainee clinical psychologist, so I just wanted to respond to the lady who was asking about the long-term therapy. I'm also a former service user myself many years ago, so I suppose I'm aware of the fact that certainly when I was younger, I was not aware that there was a psychology service within the HSE and that it was free and that it was accessible. But it actually does exist, which is why I wanted to mention it today. Now, unfortunately, there aren't many of us. So at the moment, in most of the teams that I would be aware of anyway, and I worked on a team quite similar to the particular one that was mentioned earlier with home-based treatment team in Carlow Kilkenny in my case, but we had one psychologist per team, but all of our referrals came in through psychiatry, which is something which I think maybe is not always necessary. I think it might be better if people could access us directly. Now, of course, the problem with that is, again, because there are so few of us, I suppose it's necessary for there to be a certain amount of gatekeeping, because unfortunately, not everybody might benefit. So the people who will benefit, obviously, we want to see them first. But as I say, I did just want to alert people to the fact really that it is there. It can be requested. there are unfortunately quite long waiting lists, again, due to just the lack of people working in the area. But it is there, and we're obviously, we always do want to see people as much as we can.
Okay, thank you. We'll just take 2 more now. Gentleman down the back and this lady here in the front, yeah?
Thank you. My name is Stephen Raycab. I've just completed a master's degree in psychotherapy, in psychosynthesis psychology. I also have a diploma in counselling. And I trained in another country, in Britain. I also was living in Germany during that period of time. So having grown up in Ireland, I've returned back to Ireland, and this is my first year since qualification. And I'm wondering what the role, I'm noticing a lot of conversations about specifying nurses or psychologists, and yourself, Dr. Gibbons, you have 2 psychologists. I'm wondering what the role of IAHIP and IACP trained or accredited counsellors. There are thousands of us in Ireland. Where do we come in, and how can we become part of the solution? Since the problem, one of the unspoken problems is, I spent 8 years to get here and I'm broke. So my service right now is, I am supported by the enterprise allowance of the social welfare system. And I receive 62 euros every week so that I can provide a service that I rent a room for on a sliding scale for individuals who can afford me. So my rates vary between, well, my room cost me 15 euros. So before they even walk in, regardless of my traveling, I've already spent this money. My commitment to them has been expressed in cash. And then they themselves can't afford to see me. Meanwhile, I have to provide, I take a risk because I'm in an enterprise allowance. I'm trying to build the business of therapy. So I am in a caring profession, but I'm also trying to look after my rent, pay for my bits and pieces. So why do I not hear more about IAHIP, qualified and accredited counsellors, or IACP? Why do I only hear PPI, the psychologists that are trained? Oh, by the way, I have a BA in psychology from UCD, but that's not quite the same as an MA in therapy. So why are we left out? Why IAHIP? Why IACP? And are we in competition with the nurses or with anybody else? Or are we here to provide a service to take care of psychological suffering? I realize that, of course, counsellors are not about triage, and it is more about long-term support after the medical profession, primary care profession, has identified. But how do we get involved?
Have you any ideas on that? I was unaware of the different qualifications.
I think Dr. Gibbons has alluded to the counselling and primary care service. So that's the first service that I'm aware of in Ireland. It is a national free, apart from the previous one that was particularly around people who had experienced abuse. But this one, which is the first general one, available to anyone on a medical card. That service, the counselling and primary care service, which is available to anyone on a medical card by going through their GP. So it is a service that in that sense is you have to be referred to it. But it uses counsellors across the country who have been arrangements have been made with the various counsellors. So it's using counsellors that are accredited by the various counselling bodies in Ireland. So it's obviously not using every single counsellor who wants to be a counsellor in Ireland, but it is accessing professional counsellors around the country who have been accredited.
Okay. Last word go to the lady here in the second row. There's a responsibility for you.
No pressure, thanks. I'm going to ruin it now by saying I've just 2 questions. I suppose, given that it's kind of towards the spun out, given that I suppose young people are becoming much more accessible through Twitter, through all sorts of different types of medias, emails, internets. Are we going to see a rise in, I suppose, services being provided through those mediums? You know, I know Samaritans do text, they do email. I know My Mind are available, you know, through chat, and so is Teen Line, I think. But I mean, I suppose in terms of having those regulated and accredited and knowing who's on and what services they offer, is that something we can look at going forward? It's more accessible and it's definitely cheaper than hospitals and the like. The second question I have, I suppose, is open to anyone. I suppose I also work with Exchange House, and I work on the National Traveller Suicide Awareness Project, but I've previously worked with homeless services as well. And I suppose even though they are a small population within Ireland, they make up an astronomically high rate of suicide. So for the likes of our minorities, such as the homeless, such as travellers, such as immigration, the gay, lesbian and bi and transgender community, I suppose what are we going to do when their rates of mental health and their rates of suicide are higher than our norm, and our services aren't even reaching or helping our so-called normal population?
It were ever thus in many ways, in terms of housing, in terms of all sorts of things. You, I presume, would have a view, Marie, on the online approach. It's a high risk one, is it not?
I think there's fantastic organisations who are doing stuff online. You've got the likes of Bodywise, who are working with young people with eating disorders. They've online chat rooms.
Can you hear down the back? Sorry, I think. Oh, you can, yeah.
You've got the likes of Childline, who have online organisations. Ourselves in Spun Out, we don't provide a direct counselling service or anything like that, but we do provide information online, and I think that's the way it's going to have to go. I don't think online is alone. It can do its work on its own. I think it needs to be supported with something, but definitely young people are online. If you want to connect with young people, you have to be online, whether that's providing them with information on Facebook or Twitter or through websites. I think it's stupid not to be online. We're getting there. I suppose there's still a lot of research to be done around that. It can be, as you say, it can be quite dangerous because I suppose a lot of people are accessing information online that isn't good quality information. It may not be the information that they should be getting from a health professional, so it can be quite risky. But I think that there's a lot of work going on, especially in Ireland at the minute, around providing online support. You've got TurnToMe.org, who are a fantastic organisation who are providing one-on-one counselling online, who receive funding as well to do that. So we are getting there, but it's just taking a while.
Okay. Okay. We're over our time. So I hope that this evening was useful for some people. I hope that it hasn't been too upsetting for people. And I hope that arising out of it, there will be a kind of a determination to raise the profile of the kinds of issues that have been discussed here. But in the meantime, I'll bow out. Shari, are you going to say something now, or no, or is it you, Tara? Right. Okay.
Yeah, I just like to genuinely thank everyone, not only for coming along this evening. The fact that you came here tonight shows that you're concerned about this issue. And I do believe that this is part of making the change, that the interest that you've shown tonight and the concern that you have, it will carry forward. We will carry it forward through our work. And if you made a commitment to sign up to our newsletter, that's one way of keeping in touch with some of the actions that we'll be having around the local elections and on an ongoing basis to government in terms of raising the need to address this issue more specifically. I think that this definitely has been a difficult evening in the sense that, you know, it's always painful to hear of people's negative experiences of the services, and I just want to thank everyone for being really respectful of the stories that have been shared and being able to hold each other tonight through this sharing. And I really want to thank everyone for your respect for each other. we will continue, as I say, we will continue to advocate, and I just wanted to note as well, because there was a question raised around children's access for children and adolescents in particular, and just to say that we also host the Children's Mental Health Coalition, which is an additional kind of distinct coalition advocating for better mental health services